Thank you everybody for having me today. My name is Brent Hager. I'm a psychiatrist. I practice at the University of New Mexico, and I teach to medical students, residents, fellows, pharmacy students, and nurse practitioner students. And I'm glad you all had the opportunity to hear from Dr. Davin Quinn, and we'll be hearing from Dr. Lucas Dunkley, two of my colleagues who I think very highly of. So I'm glad you're having those opportunities as well. And let me see if I can share the screen here. Bring up the window for the talk. All right. And maximize this. And please a thumbs up from folks if you all can see the slides. Thumbs up. Okay, great. Wonderful. Thank you. So we're going to talk about some cannabis use considerations for people with a SMI diagnosis, and we're going to focus on some take-home points that you all can take with you to think about and to read about and to consider. I don't have any conflicts of interest to disclose. I hope by the end of this talk, you can appreciate the body's natural cannabinoid system, understand some of the active components of cannabis and how they may work, describe the impact of cannabis use on psychosis and bipolar disorder in particular, and then appreciate the role of THC and CBD and cannabis use decisions. And as we go through the talk, folks are welcome to unmute and ask questions. I will have a little bit of a difficult time monitoring the chat function. And so if somebody chats in a question, then please either Tom or Jessica, is that your name, Jessica? Yeah, from NAMI Santa Fe. Please just let me know if there's a chat and I can answer that as well. So,
will do.
Go ahead, Tom.
I just said will do. Thank you.
Okay. Thank you. So some points of departure. The majority of cannabis-related literature focuses on its risk as a recreational use or as a use disorder substance. And the minority of cannabis-related literature focuses on its therapeutic uses, although that literature is growing steadily, especially as more and more localities adopt medical cannabis statutes and more localities legalize cannabis for recreational use. There's some similarities and differences that are unclear between people who use cannabis primarily recreationally and people who use cannabis primarily medically. And so it appears that these literatures are tapping into different patient populations. Most studies of therapeutic uses of cannabis utilize pharmaceutically prepared cannabinoids, like individual cannabinoids, which we'll go through in a few slides here. And then the cannabinoid content of medical cannabis preparations differs from that of research preparations. The researched cannabis, when cannabis use is researched in a controlled setting in the United States, it's usually using cannabis from a farm in Mississippi that is run by the National Institute of Drug Abuse. And that cannabis tends to have much lower THC concentration, similar CBD concentration, and slightly different terpene concentrations than most medical cannabis strains that we see on the market. Cannabinoids other than THC and CBD remain underrepresented in the therapeutic literature, and the terpenes remain underrepresented in the therapeutic literature. So these are some caveats to keep in mind as we go through this talk. So the first take home that I wanted to share is that our bodies have a natural cannabinoid system, and this natural cannabinoid system serves some very important functions. So the two main cannabinoids in our body are endocannabinoids, they call them, are anandamide here on top and 2-AG here on bottom. And they look somewhat similar with a similar sort of base group and some similar substitution groups here. And these are metabolized or synthesized by the body on demand, and we'll see what the function of them is in the nervous system in particular. The body has several cannabinoid receptors, and so these are receptors that receive these our body's own cannabinoids, and with that reception have specific actions for our neurons. So the Cb1 receptors are found in the brain, the spinal cord, nerves, but also in some organs, the fat, liver, pancreas, and muscle. And these are stimulated by anandamide and 2-AG. The cannabinoid 2 receptor, Cb2 receptor, found on, on immune cells. It's also found in the brain and spinal cord, but its role in the spinal cord and the brain is unclear. This one is also stimulated by anandamide and 2-AG. And then there's a receptor called the TRPV receptor, which is found on pain-sensing nerves, and it's stimulated by smaller amounts of anandamide and inhibited by larger amounts of anandamide. And this has to do with the transmission of sensations of pain, burning, and temperature sensations. So the second take home that I wanted to pass on to you all is that our body's cannabinoid system helps to balance our brains. And how it does this is it acts as a messenger that goes from a neuron back to the neuron before it to tell the neuron before it, okay, that's enough, you can shut down now. So the neuron, this neuron up here will release these neurotransmitters to this second neuron. And in response to receiving these neurotransmitters, the second neuron will synthesize and release anandamide or 2-AG, which will come back to this previous neuron and will basically shut down this previous neuron from releasing more neurotransmitter. So it's our body's way of helping to make sure that we don't get too much neurotransmitter release. And this is a major mechanism of, we call this negative feedback. So the second neuron says to the other one, okay, stop doing what you're doing. And this is true for glutamate neurons. Glutamate is the major stimulating neurotransmitter in the brain. This is true for GABA neurons. GABA is the major inhibitory neurotransmitter of the brain. And it's true for dopamine neurons as well. Dopamine can be a stimulatory or an inhibitory neurotransmitter depending upon the type of receptor that it stimulates. So the endocannabinoid system, or the body's own cannabinoid system, helps us to maintain a very careful balance of our neurotransmitters. The third take home that I'd like to share with you all is that cannabis is not a single drug. The cannabis plant, in particular the flower, which is usually the part that's consumed either by being smoked or being concentrated into an oil and then being either smoked or consumed orally, the cannabis plant has numerous cannabinoids. The two that we know the most about are THC and CBD here. CBD is here, THC is here. But there are numerous other cannabinoids. And in fact, there are probably about 60 different cannabinoids in cannabis. And a lot we don't know about, there's a lot we don't know about these other cannabinoids. But it's believed that these other cannabinoids don't have psychoactive effects, so they don't create intoxication. It's believed that THC is one of the only psychoactive or intoxicating cannabinoids in cannabis. CBD is not an intoxicating cannabinoid. Cannabis also has a variety of other compounds called terpenes, and terpenes are compounds that give things their scent or their smell. And so the terpene linalool is found most commonly in lavender, limonene found in citrus, pinene, of course, found in pine, caryophyllene found in cloves or pepper, terpinolene found in sage and nutmeg, and myrcene found in mango and hops. And there are more terpenes that are involved with cannabis. There are quite a few more actually, and they give cannabis its distinctive smell, and the mixture of terpenes give it its distinctive aromas that different cannabis preparations have. And these in themselves may have some effects on the brain, although not intoxicating effects. For example, limonene appears to partially block or partially moderate the psychosis-related effects of cannabis intoxication. And there are reports or stories of a traditional North African remedy for when people got too intoxicated with cannabis is that they would basically make a lemonade for the person to consume that would help to bring the intoxication down. Linalool, or lavender, has been studied as a treatment for anxiety and depression. And there are some randomized controlled trials using linalool for anxiety and for depression. Limonene is being explored as a potential antidepressant. When you go to medical cannabis dispensaries, they have these very colorful graphics to describe all the different terpenes. This graphic is from a British Columbia newspaper. And sometimes you'll see these terpenes listed with a range of effects. They'll say, this is the terpene, this is what the effect it has. Most of those effects that are listed are based upon either basic science research or animal models, and most of those effects that are listed are not based upon clinical trials in humans. So one of the take-homes along these lines is that when you see claims about this particular strain is effective for this, it's usually based upon either basic science research or a person's anecdotes, or a collection of anecdotes from people who have used that particular strain. So the fourth take home I wanted to share is that the different cannabinoids have pretty different effects. So THC, the main psychoactive cannabinoid in cannabis, it partially stimulates Cb1 and Cb2 receptors, and this has intoxicating effects. And it does this in part through increasing dopamine release in the part of the brain that's associated with reward. And you can think about it in terms of it disrupts the brain's careful balance and tips it into a direction where there are some perceptual abnormalities, some motor control abnormalities, and also things like euphoria, and sometimes paranoia and anxiety. CBD appears to stimulate some serotonin receptors. It gently increases anandamide levels by inhibiting the breakdown of anandamide, but it does not appear to have intoxicating effects. And we'll talk more about CBD and its potential use in schizophrenia in particular in a few slides. The other cannabinoids, much less is known about their effects in humans. There are no known intoxicating effects of the other cannabinoids. And then terpenes, as we talked about, have some various effects, no known intoxicating effects. So the fifth take home that I wanted to share is that cannabis use does have some potential benefits. Perhaps the best studied benefits for the use of cannabinoids is THC or THC-CBD mixtures appear to have some pretty robust evidence for treating chronic pain, including cancer-related pain, also for treating chemotherapy-related nausea and vomiting, and for treating multiple sclerosis-related spasticity. They're using THC for chemotherapy-related nausea and vomiting. This is the main FDA-approved indication for THC in the United States. Its use in chronic pain is not FDA-approved, but it has some pretty good evidence. And its use in multiple sclerosis-related spasticity is approved for this in Canada and in Europe using a 1-to-1 THC-CBD mixture called nabiximols. Now, CBD has evidence for treating schizophrenia and is being studied as a potential treatment for bipolar depression. And as you may know, the depressive phase of bipolar illness is the most difficult phase to treat. And so it's nice that we're exploring other options. We'll talk more about its use for, its potential use for treating schizophrenia in a few slides. Small doses of THC may have some cognitive benefits in bipolar disorder, and we'll talk about the risks that are associated with cannabis use in bipolar disorder in a couple of slides. Lastly, cannabis effects on PTSD are unclear. Small doses of THC at night may help with sleep-related, PTSD-related sleep disturbances. There was one small trial that is being published presently that looked at smoked cannabis and PTSD, and it showed no difference between active cannabis and placebo cannabis. So the active arms had like high or low THC and high or low CBD. The placebo arm was low THC and low CBD. So cannabis's benefits in PTSD, it's not clear if it's just the terpene content or the other cannabinoids that are making this action possible. Because in that particular study, it didn't appear that the presence or absence of THC or CBD had bearing on the outcome. In contrast, there have been a number of anecdotal reports, some using very large groups of people that are uncontrolled studies, suggesting that many people with PTSD who use cannabis experience some improvements. And there also have been studies that show that people who start cannabis use or continue cannabis use when they're receiving PTSD treatment tend to have worsened outcomes in PTSD. So it's a big open question, and hopefully further randomized controlled trials can be accomplished that could tell us more definitive answers about the role of cannabis in the treatment of PTSD. And this is especially important because PTSD is the #1 condition for which people in New Mexico receive a diagnostic certification for the medical cannabis program. And cannabis's potential benefits, we should think about the positives of the intoxication syndrome as potential benefits just from a purely subjective standpoint. When people make decisions to use cannabis, this is part of their decisional matrix. So the positives of the cannabis intoxication can include euphoria or feeling really good. It can include calmness, boosting of the appetite, increasing sociability, time perception alterations, color perceptions being heightened. Those can, of course, be either good or bad, depending upon the subjective experience of the person. But these are some potential benefits from the intoxication syndrome from a subjective standpoint. Now, the next take home is that cannabis use has some potential harm. And as we talked about in that first slide, that point of departure slide, that most of the literature on cannabis has focused on its harms. And so we know quite a bit about cannabis harms. There are some negatives to the intoxication syndrome, which can include impairment of cognition, judgment, and motor coordination. This may be why cannabis use can be associated with an increased risk of motor vehicle accidents and fatal car crashes. Panic can occur. Paranoia and hallucinations can occur, and it can cause red eye, dry mouth, and fast heartbeats. And we'll talk a little bit about how cannabis use is associated with a temporary increase in the risk of myocardial infarction in people who are at risk for that, for heart disease anyways. And then cannabis withdrawal can be unpleasant for people, and this is part of why people continue to utilize cannabis after they've used it for some time, is because it can cause irritability, anger, aggression, anxiety, can disturb people's sleep, can decrease appetite, cause restlessness and depressed mood, and abdominal pain, tremors, sweating, fever, chills, and headache. And this acts as what they call a negative reinforcer for continued cannabis use. So if you stop something and you feel worse after you stop it, you're naturally inclined to continue it. And this can be a big barrier for helping people with a cannabis use disorder as well. Some other harms that we know of, about 1 in 10 people who first use recreational cannabis go on to develop a cannabis use disorder. So the risk of developing an addiction to cannabis is about 10% in recreational cannabis users. We don't know what this number is in people who use medical cannabis. People who use earlier, who start using earlier, and who use more are more at risk for developing a cannabis use disorder. This also means that 90% of people who first use cannabis recreationally do not go on to develop a cannabis use disorder. Recreational cannabis use at baseline is associated with an increased risk of developing a number of conditions that follow up. This is evidenced from the National Evaluation of Substances, National Evaluation of Substance Abuse and Related Conditions. This is a epidemiologic study that's ongoing. And what they did is they took a look at cannabis use at baseline and during the first wave of the survey, and then I think 12 months later, the second wave of the survey, they estimated what the risk was for people developing these other conditions. So anywhere between a 2 and 5 times increased risk of developing any number of other mental disorders, including other substance use disorders, as well as depression, bipolar disorder, and schizophrenia. And there are various theories about why this might be the case. There are self-medication hypotheses. There are hypotheses that there's a common underlying risk factor for both cannabis use and for the development of a mental disorder. That one appears to be true when we're considering depression. For schizophrenia in particular, and we'll talk about this in a little bit, this doesn't appear to be a common genetic risk. It appears to be like there's not a common genetic risk that increases the risk for both cannabis use disorder and psychosis. It's that people who are at risk for psychosis are vulnerable to the effects of cannabis use. And then some other potential harms. There's been an association with low birth weight in offspring of mothers who smoke cannabis while pregnant, and some increased attention and behavioral problems in offspring of mothers who smoke cannabis while pregnant. There tends to be poor cognitive, academic, and vocational outcomes of people who smoke cannabis in adolescence. 2 times increased risk of a motor vehicle accident. And this has been shown in localities where cannabis has been legalized. Increased risk of heart attack around the time of smoking. It appears to be within like minutes to an hour around the time of smoking, like after smoking. This could be due to the increased heart rate that can happen when cannabis is consumed. There's also a time-limited increased risk of stroke. And then cannabis does appear to exacerbate schizophrenia, bipolar disorder, and depression in certain people. It's not a guarantee that it'll worsen these things, but it does have a risk for worsening these conditions. And there's this last one, there's studies that look at cannabis use earlier in adolescence can increase the risk of suicide later on in adolescence. So there could be an increased risk of suicide in vulnerable people. Cannabis use is quite common in schizophrenia and bipolar disorder. So as we can see, past year use of cannabis in schizophrenia is 23%, past year use disorder 23%, and then lifetime use 42%, lifetime use disorder 27%. So about 1 in 3 people with schizophrenia will have a lifetime cannabis use disorder. And the number is quite similar for people with bipolar disorder, where about 1 in 3 people have a lifetime use disorder. And bipolar disorder, people with bipolar disorder tend to have a much higher rate of lifetime cannabis use, just use in general. And we know that that bipolar disorder is a condition that conveys particularly increased risk for substance use disorder co-occurring. In contrast, in the general population, past year cannabis use disorder is about 3%. So there's the presence of diagnosis of schizophrenia or the diagnosis of bipolar disorder can increase substantially the risk of having a cannabis use disorder. And cannabis use appears to be a risk factor for psychosis and for bipolar disorder. And we hinted at this earlier. Cannabis use increases the risk of developing a psychotic disorder in particularly vulnerable persons. So these are people with a family history of psychosis, people who have adverse childhood events. The more adverse childhood events that somebody has, the more they appear to be at risk for the development of psychosis related to cannabis use. And adverse childhood events are things such as abuse, neglect, witnessing violence in the home, witnessing substance use in the home, also parental separation, and separation from the parents. There's some potential risk genes for this, although that literature is still not quite clear. And as with most psychiatric genetic research, these risk genes appear to convey a very small amount of risk with each gene. And then possible mechanisms of action include the disruption in brain balance. Remember we looked at those neurons before and how the endocannabinoid system helps carefully regulate the balance of neurotransmitters. When we disrupt this in adolescents, in people who are vulnerable to this, it can start a cascading effect that results ultimately in psychosis. And in fact, in the diagnosis of schizophrenia. Those who use cannabis in adolescence have a 2 to 3 time increased risk of developing a psychotic disorder. We saw this before. People who use heavier amounts of cannabis and who start to use earlier appear to have a greater risk. And then lastly, those who use cannabis have about a 2 to 3 times increased risk of developing bipolar disorder and an increased risk of developing an early onset of bipolar disorder. So this is important information, I think, especially for the families of people with serious mental illness, and educating the children of those families when they're trying to make decisions about their substance experimentation. This is a nice a graphic that is demonstrating how, in the majority of youth, in the critical neurodevelopmental stage, the use of cannabis doesn't necessarily have much of an impact on synaptic plasticity, meaning the changes in the synapses, and there's minimal or no structural or functional changes, and they can use cannabis without much consequence. And those with risk, the environmental risk is the adverse childhood events, the familial risk is the risk gene for psychosis. This appeared to have some deleterious or negative effect on synaptic plasticity, which may also be accommodated or accompanied by increased dopamine release in the reward centers of the brain and structural brain changes, ultimately leading to psychosis. Next point is that cannabis use tends to worsen psychotic and bipolar illness. This is a risk that you can see when you look at large groups of people with these illnesses who utilize cannabis. And it's, like I said, it's not a guarantee that every person with schizophrenia or another psychotic illness who uses cannabis is going to have their disorder worsened. It's just a risk for them worsening it. Same thing with bipolar illness. So cannabis use in psychotic illnesses is associated with higher relapse rates, longer hospital admissions, and tends to have more severe what they call positive symptoms, hallucinations and delusions. Cannabis use in bipolar disorder is associated with more frequent manic and depressive episodes, more rapid cycling, more mixed episodes, and generally poorer long-term outcomes. Next, on a hopeful note, CBD shows some benefit in schizophrenia. This is a small clinical trial that looked at CBD in comparison to amisulpride, which is an antipsychotic that's available in Europe. And what they found is that the CBD arm and the amisulpride arm each improved about the same on these scales of psychosis. So a drop in psychosis symptoms by about 35 points or 30 points for both groups. A drop in total psychosis symptoms, a drop in the positive symptoms, which is hallucinations and delusions, and a drop also in the negative symptoms, which is the negative symptoms of schizophrenia are the limited emotional expression, difficulty with emotional reciprocity, limited interest, limited pursuit of pleasurable activities. The negative symptoms appear to improve more in the CBD arm than they did in the amisulpride arm. So this was really interesting research, and then this was followed up by a larger clinical trial that confirmed these benefits. And this clinical trial looked at the use of CBD as an adjunct to an antipsychotic medication. So these were people with schizophrenia who were taking an antipsychotic and finding partial benefit from the antipsychotic, and they randomized them to receiving adjunctive cannabidiol or CBD versus placebo. And you can see here, this is the mean change in the psychosis score. And this is day 8 of treatment. day 22 of treatment and the end of treatment. And you can see how the decrease in the psychosis score was greater than the decrease in the placebo arm. It was greater in the CBD arm than in the placebo arm in all the time points. And so more research is being done on the potential use of CBD for the treatment of schizophrenia or the augmentation of antipsychotics. And like I said in a previous slide, also being studied as a potential treatment for bipolar depression. So stay tuned. And by the way, the doses of CBD used in these studies are somewhere between 200 and 600 milligrams a day. And so these are really robust doses of CBD that are being used, and it can be very hard for people to afford this kind of dose out of pocket if purchasing from a CBD boutique or a medical cannabis dispensary. Next take home, now CBD in general may protect against the psychotic effects of THC, not only in people with a psychotic illness, but also in people without a psychotic illness. And studies of long-term and short-term CBD intake show that CBD tends to reduce THC-related psychotic symptoms. It tends to reduce THC-related cognitive impairment, and it tends to reduce THC-related brain shrinkage. So long-term THC use can shrink the part of the brain that's responsible for memory. This appears to be a reversible effect that can cease upon some months of cannabis cessation, but CBD can help prevent that shrinkage of that memory part of the brain. And then lastly, cannabis use risk-benefit decisions are really challenging. And there are some proposed contraindications that I'd like to suggest for cannabis use. So these are conditions in which cannabis use, in particular THC containing cannabis use, I caution people about cannabis use when they have these kinds of conditions. So folks who already have a cannabis use disorder, that the cannabis use disorder, by definition, that's when the cannabis use itself is causing some harm. And so that's an opportunity for an intervention as opposed to an opportunity for necessarily continued cannabis use. Although with patient-centered medicine, of course, it's always going to be up to the person with the use disorder what they want to do in terms of addressing it. Schizophrenia and bipolar disorder I think, are still relative contraindications for recreational cannabis use. And under those conditions, I would suggest some caution. People with high degrees of suicidality, because of the evidence that they can sometimes worsen suicidality. And then cannabis use prior to full neurodevelopment, because adolescence and childhood are very critical neurodevelopmental times. And the brain starts to fully develop stops developing in the mid to late 20s. And so when we work with our pediatric patients, we're oftentimes encouraging them to defer cannabis experimentation until after neurodevelopment has occurred. And then some proposed cautions, caution in PTSD, caution in depression, caution when folks have a non-cannabis substance use disorder, and caution if there's high cardiovascular or cerebral vascular risk, and then also caution if there's chronic bronchitis. Smoked cannabis tends to worsen chronic bronchitis, although it doesn't appear to worsen asthma for some reason. There may be a balance of pro-inflammatory and anti-inflammatory effects of smoked cannabis. And then I think one of the reasons why it's really particularly challenging to make these risk-benefit decisions is that all of us as humans tend to struggle with decision-making in general. And in particular, decisions involving pleasurable activities may be particularly difficult for all of us as human beings. And so this is the decisions around cannabis use are no exception. Folks with schizophrenia, folks with bipolar illness, they oftentimes utilize cannabis because it makes them feel good. And it makes them feel good in short-term terms. And they may have a hard time observing the long-term trajectory of a worsening course of illness. because the pleasurable effects are more convincing than the possible long-term worsening of a trajectory of illness. Denial is a prominent feature of cannabis use disorder, as it is with many substance use disorders. And speaking with a loved one about their cannabis use or cannabis use disorder can provoke distress, irritation, conflict, just like it can when you speak with relatives about other use disorders. Direct confrontation is not typically successful in these instances. There are some approaches like motivational interviewing that we use when we're interacting with folks with a substance use disorder that help us to understand where the person is coming from and get a sense of where they're at with their desire to change their behaviors and what they might, what factors might help to enhance their desire to change their behaviors. For family members who are speaking with their loved ones, there's an approach called CRAFT, which stands for Community Reinforcement Approach Family Therapy. And CRAFT essentially encourages making contact with loved ones who have a use disorder through reinforcing pro-social behaviors and not trying to punish substance use behaviors. So you're reinforcing the behaviors that are pro-social and that are not related to substance use. So for example, reinforcing with somebody that, you know, I really like it when we get to hang out together when you're not high on cannabis, because I feel like we have much better conversations, and I really appreciate that. And I appreciate that when we hang out together that you don't smoke before we hang out together. So it's a different approach than sort of saying, I really don't like it when we hang out and you're high. So you're trying to encourage the pro-social non-substance use behavior. And there's a book about craft called Get Your Loved Ones Sober, which is a little bit of an overbearing title, but the principle of the matter is that these approaches can be helpful for family members and can also be helpful for the people themselves, because clinical trials of the craft approach show that when the family uses these approaches, the person with a substance use disorder can have improvement in their use disorder. And then lastly, knowledge of THC, CBD, and terpene content can be useful. CBD supplementation or utilizing balanced strains may protect against some psychotic effects. And I'm frequently in my patients who utilize medical cannabis, I'm having a lot of dialogue with them about what strains they're using, what effects they're having, tracking their symptoms of worsening, tracking for worsening of psychosis or suicidality, and collaborating in this way can be helpful. And knowing the terpene content, so there are some broad strokes, like for example, the limonene, the terpene that's found in citrus fruits, tends to have like a kind of a brightening or activating effect, whereas myrcene, the one that's associated with hops and mango and myrrh, it's called myrcene because it's named after myrrh, the incense spice. That one can have a really sedating effect. So just in summary, THC-containing preparations, those are summaries from my previous talk about cannabis and chronic pain. So to summarize, our bodies have their own endocannabinoid systems. The endocannabinoid systems help us to carefully regulate our brain balances and our balances in our neurons. Cannabis use can have some clear benefits, in particular the treatment of chronic pain conditions and the treatment of nausea and vomiting related to chemotherapy. And the CBD evidence for schizophrenia is promising. And cannabis use can also have a number of risks associated with it, in particular risks associated with its use in the setting of a severe mental illness. And that's, it can be very challenging to make individualized decisions about cannabis use, and collaboration and support and continuing like to have a loving relationship with a loved one who has cannabis use are very important parts of continuing the discussion about cannabis use and helping them in their decisions about use. So I will stop sharing here and take questions.
Thank you, Dr. Hager. Absolutely fascinating and a very rich amount of material that you put forward. One of the things I wanted to ask right off the bat, because I got several queries in the chat, would it be possible to get a copy of your charts? Because
yeah, I'd be happy to share my slides. I'll edit out that summary slide so it's relevant to the talk, and then
I would appreciate that, because I think a lot of people would, we covered a lot of material. We covered it quickly. It'll be on the video, but I'm sure some people still would like to see the charts. So thank you very much. And I did have one question, and that is sort of, what is your prognosis for what's going to happen with cannabis research and guidance as more and more states, like perhaps New Mexico, are going to go forward and legalize cannabis? Are we going to get a rich stream of information, guidance, and scientific results that will help people make good choices?
It's unclear about what's going to happen research-wise. If you look in House Bill 12 that just passed, of course, and was signed by the governor, that legalized recreational cannabis use in New Mexico, there is talk in that bill of having surveillance from a public health standpoint on rates of things like motor vehicle accidents, rates of mental illness diagnoses. And there's talk of the potential for some form of a research fund from revenues generated by sales of cannabis. And it's not clear to me how that's going to pan out, and if there will be takers from the industry in particular who are going to be willing to exert the effort to do systematic study. There are some medical cannabis companies that do fund medical cannabis research. So, for example, that Ptsd study I shared with you was funded in part by a major medical cannabis manufacturer. Although right now, I think medical cannabis establishments, medical cannabis producers and sellers, and recreational cannabis producers and sellers in other localities, I don't think they have much of an incentive to contribute in a very meaningful way to the literature on cannabis's use and risk, because they have a business model where already there's a positive perception of medical cannabis for a wide range of conditions, and so there's not much of a impetus to sort of modulate that flow of business and customers by subjecting it to more rigorous study that may come out with negative results.
Thank you.
So it's really, I'm not particularly optimistic that it's going to result in a huge influx of detailed literature. I think the literature is probably still going to be driven by academic medical centers, unless there's a change in the regulatory structure. If cannabis preparations were treated like other psychiatric medications, the cannabis preparation would have to demonstrate proof of benefit and proof of a benefit that outweighs potential risks in controlled trials. But with the trends that are going on right now in medical cannabis, I don't see that happening, that kind of rigor occurring before say a dispensary can, or say a medical cannabis advisory board can approve a new condition. The level of evidence is simply not the same that they use to approve new conditions.
Excellent. Thank you.
It'll be interesting to see how it pans out in the next 5-10 years. So thanks, Tom.
Let me throw it open to other questioners. I see Jessica's hand up.
We have one from Facebook. What if your loved one has been diagnosed with schizophrenia after heavy marijuana use, but then stops the use and the symptoms subside, but along with medication? So how do you know that the diagnosis is correct?
Yeah, that's a great question. There are numbers for each substance when it creates a psychotic illness. There are certain percentages for who goes on to have a persisting psychotic illness even after the cessation of that substance. And cannabis is actually the highest risk substance in terms of if you develop psychosis while utilizing cannabis, you have I think it's around a 40% chance of having persisting psychotic symptoms after the cessation of cannabis use. And then for the DSM, I mean, the DSM suggests that you use a cutoff of a month after cessation to discriminate between a substance-induced psychosis and an independent psychotic disorder. And certainly if you're seeing psychosis persisting 6 months out or a year out after cannabis use, chances are that that person has gone on to develop a psychotic disorder that will persist. I work with a number of patients who develop psychosis while using methamphetamine and have had psychosis during methamphetamine, and then it's persisted for a while and subsided, and then it tends to sort of rear its head under circumstances of increased stress, or say they use like once again, like if they just have a single use, or they use another substance that can have psychotogenic properties. So it's a great question in terms of diagnostic clarification. I would say that if the diagnostic criteria are met for schizophrenia, meaning that the disturbance has been present for 6 months or greater after the cessation of the substance, then you would the behavioral health person would go ahead and make the diagnosis of schizophrenia. Now, the schizophrenia can always remit. It doesn't happen that commonly for when schizophrenia develops in the teen years, in the 20s, but it can certainly have a different pattern than just a chronic descending pattern.
Thank you very much. Let's see, we got 2 hands up. Why don't we go with Terry first, and then we'll follow with Craig.
Yes, thank you, Dr. Hager. While we were talking about the deleterious effects of cannabis use for psychotic illness, could we flip it a little bit to the more positive impacts that are being studied increasingly about the use of CBD for those with psychotic illness? And do you, in your practice or others at UNM, are you looking more into that area, even as a, in conjunction with antipsychotic, neurologic medications?
Yeah, I encourage people with psychotic illnesses, especially if they're using cannabis, to supplement with CBD. And as I was sharing, it can be hard for people to afford CBD out of pocket at the doses that are used in those studies. That's the major barrier. Now, there is a CBD preparation that is available for the treatment of juvenile myoclonic epilepsy. That's called Epidiolex. Mm-hmm. The name of that medication. And so I think when that goes off patent and becomes hopefully more affordable, we may be able to utilize it for off-label treatment as augmentation for schizophrenia. And it's possible that in the intervening years, the company that makes Epidiolex may study it more and find it and get an FDA indication for its use in schizophrenia.
Go ahead.
Yeah, it's really tough. I mean, it's for people to afford 300 to 600 milligrams a day of CBD.
Thank you. Craig?
Yeah, thank you. Thank you, Dr. Hager, for your presentation. It was very enlightening. I was wondering, are you aware of any research that has looked at the extent to which moderate to heavy cannabis usage impacts the effectiveness of antidepressant medications like the SSRIs or any of the other mental illness medications that are, commonly used?
Yeah, there are some theoretical concerns about drug-drug interactions and changing the levels of various medications, although one reassuring thing is that there was a recent study that looked at the impact of controlled amounts of cannabis intake on the blood levels of some opioid medications, and it didn't appear to alter the opioid medication level in the blood. And so my suspicion is that the influence of cannabis, regular smoked cannabis, would probably be pretty minimal on drug levels of SSRIs and SNRIs. Now, CBD may have some more inhibition properties, and so it's not clear yet to me whether or not higher doses of CBD may have drug-drug interactions. The therapeutic impact, so that there's not been much study, particularly of cannabis, cannabinoids, or on depression as an illness or anxiety disorders as illnesses. So there's a lot that we don't know. What we do have are observational studies that look at people with, say, depression who smoke more versus less cannabis, and those folks tend to have slightly worse outcomes and slightly more suicidality. Whether or not this is people with a more severe illness course who are selecting cannabis use to alleviate suffering, it's not clear yet. And so what we would need is clinical trials really to tease that apart, to tease the causality apart. Now, cannabis use long-term doesn't appear to exacerbate anxiety disorders long-term. So, I mean, that's a positive, I think, for folks who are using it to try to manage anxiety disorders. Yeah, thanks, Greg.
Thank you very much. I have a question that came up in the chat, and let me read it, and we may need to ask for clarification. The questioner says, it's easy to walk into a dispensary and self-diagnose and be given a script when in fact they haven't really had a proper diagnosis. Are dispensaries educated with the risk and of putting cannabis into the wrong hands?
Yeah.
And sort of how should a loved one deal with the possibility of this situation and the potential impact on other family members?
Yeah. Yeah, I've seen a lot of variability with different dispensaries in terms of how much they pay attention to potential risks and how carefully they make a diagnosis and how carefully they make recommendations for the products that they encourage. Many dispensaries are have association with a physician or a nurse practitioner or a physician assistant who makes a diagnostic certification for that particular patient. And this arose, I think, because so many physicians can be so wary of making the diagnostic certification because of concerns about cannabis and cannabis use. My experience, and this is just my own anecdotes, has been that those providers who are associated with medical cannabis dispensaries can be rather permissive with the certifying diagnoses. And then when the medical cannabis program is a really interesting one because there's nothing else like it in medicine. So the analogy I use is, say somebody comes in to a provider's office and gets diagnosed with depression, and the provider gives the patient, the person with depression, a script that says, you have depression. And then the person goes to a pharmacy, and with that letter is permitted to pick out any SSRI or SNRI that they would like. With a huge dose range based upon the recommendation of a person who has used one or two SSRIs or SNRIs, or maybe used several of them. And so when you think about it in that way, it becomes clear that mechanism of doing things is very different from how we operate normally in medicine. So there are a lot of uncertainties about what happens for a person with a certifying condition who gets certified, who then walks in the door of a dispensary and works with usually some form of a bud tender or somebody who has a lot of anecdotal experience with cannabis use. And this is why I ask when I'm working with people who have certification for diagnostic certification for medical cannabis, I ask them to collaborate with me on their strain selection, to share with me what the THC and CBD content are of their strains, and to carefully monitor how things are going for their symptoms.
Excellent. Thank you.
On that
Betty?
note, yes, on that note, Dr. Hager, thank you again for your talk. You mentioned strains, and I know that there are different strains of cannabis that have different effects.
Yeah.
So I was wondering about all these studies that you quoted. Do any of them isolate any of those strains, or is it cannabis is cannabis kind of research?
Right. Yeah. So the risk research, a lot of it focuses on just recreational cannabis use, and that will depend upon the strain that's prevalent in that community around that academic medical center at that time. And given that there are 600 or 700 different cultivars of cannabis that are dispensed in medical dispensaries and recreational cannabis dispensaries, it's really hard to keep up with that and to understand the effects of all the different strains.
Mm-hmm.
Many, like the New Mexico Medical Cannabis Program, requires that the CBD and THC content be analyzed and reported on each container of medical cannabis, but they don't have requirements around terpene content. So there have been a lot of creative efforts to try to understand the subjective effects of different types of cannabis from groups of like thousands of users. There's one particularly creative one that looked at the smell of the cannabis as it was advertised compared to the subjective response that was reported on a cannabis-related, medical cannabis-related app. And this one really tries to tease out which terpenes are having which kinds of subjective effects. And I think more creative research like that is going to be needed to understand, like, you know, what particular effect this strain might have on most people.
Mm-hmm.
Yeah.
Excellent.
Okay, thank you.
Thank you very much. We have one other question. Jess, do we have any more questions on Facebook?
No, there was just another one in the chat. I don't know if you saw that, Tom.
I was going to read the one in the chat, and I may need some help from the person who submitted it. But it says some cultures use low-grade natural marijuana at low levels of active ingredients. What does the data suggest about that compared to what you can get now, which has so much higher potency?
Yeah, we've seen trends, continual trends from the 1970s onward that have demonstrated steady increases in THC content in particular, with either similar or decreased content of CBD. And the terpene content is not clear because it's not been on people's radars for a long, long time. And so, for example, cannabis that was acquired in the 1970s may have THC content of like 2 or 3, maybe 4%. And when we're seeing dispensaries now, or cannabis flower that has a THC content of 20 or 30%, and the availability of cannabis concentrate that may have 70, 80%, or even 100% THC. And so given that higher amounts of use, more frequent use, tends to drive some of the increased risk of developing a use disorder and drive some of the increased risk of developing a psychotic disorder or earlier onset of bipolar illness, there is certainly is concern with higher and higher potency strains contributing to greater long-term risk.
So it would be possible that if cannabis with the 2 to 3% level had some balance of CBD in it, and then when you concentrate the THC but not the CBD, it really is could be a very different drug with very different
Yes.
effects.
Yes. Yeah. Yeah. What cannabis is not cannabis. Like cannabis is a huge plethora of different preparations. And yeah, the amount of THC has a lot of implications for, I think, for risk of developing other conditions. And there are some studies, like for example, the study that looked at cannabis use at nighttime, that used a synthetic cannabinoid at nighttime for helping with PTSD-related sleep disturbances, used a very small dose. And cannabis literature that looks at the treatment of chronic pain, they find this U-shaped curve with moderate doses or smaller moderate doses having some anti-pain properties, and larger doses having almost no anti-pain properties or decreased anti-pain properties. And there may be, like for example, people are looking at cannabis in bipolar illness, because there's some suggestion that cannabis may improve cognition in some people with bipolar illness. So is that an effect of dose amount? And in carefully regulated dose amounts, could it in fact improve some cognitive outcomes? And if that's the case, then how do we help people to modulate their cannabis use? There's a lot of dose response questions that are still out there.
I have another question. You've talked about the studies, and I wondered if there's been any distinguishing in those studies between the traditional or more old school smoking of cannabis versus the increasing amount of edible preparations.
Mm-hmm.
And if the studies have delineated between those two things.
I don't think the studies have delineated between those two things in any sort of regular or robust way yet.
Seems like that might be interesting to pursue, right, in terms of the research?
Yeah, I think it would be interesting. I
How
mean,
it's metabolized and,
Right, and like there's one study that looked at smoked cannabis versus I think it was intravenous THC on the impact of cognition and schizophrenia. So there are some studies that are looking at different ways of administering it and using like the purified compounds versus the whole plant compound. And it's really young literature still.
Excellent. Dr. Hager, thank you very much. Outstanding presentation. I think it was right on point for many of our members. And we really, really appreciate your presentation, the material you've presented,